Hello, this video is a small portion of a complete comprehensive video. If you'd like to see this complete comprehensive case and many other complete comprehensive cases, click on the link in the description below. I like to use my rubber dam technique on almost everything. It keeps the pieces of the old crown or old restorations from falling into the patient's mouth and having them have to worry about aspirating or swallowing it. It also keeps 99% of the water out of the patient's mouth. It's a lot easier on the assistant to aspirate. So I use a rubber dam for almost everything. Even if I'm extracting a tooth that's not the terminal tooth in an arch, I'll many times use a rubber dam just because it's so much easier as far as containing the water. If there's any pieces of anything, it's not in the patient's mouth. So I'm cutting off these old crowns. I just use a coarse barrel diamond and cut through the porcelain. This is a PVC. Now the worst crowns to cut through, of course, are zirconium. And you just have to use a light touch with that coarse barrel diamond and just slowly cut through the zirconium. Lithium disilicate's also more difficult to cut through than porcelain, but it's not as difficult to cut through as zirconium. Cutting between these teeth so I've got an area to elevate the pieces of the crown into. Then that rubber dam just keeps it all contained, so we're not worried about anything falling into the patient's mouth and potentially being aspirated. Place the rubber dam and watch the rubber dam technique that I'm teaching. I think you'll really like it. It's a lot easier than the conventional technique, and it accomplishes 99% of the conventional rubber dam technique, mainly keeping everything out of the patient's mouth. I'm using a coarse barrel diamond to cut through the porcelain. Then I'll use the 330 carbide burr to cut through the metal if it's a porcelain to metal crown. This seems to be either zirconium or a lithium disilicate Emax crown, and those are harder to cut through than porcelain. My veneers and most of my crowns, if they're not gold, are lithium disilicate Emax. I really like gold crowns or gold onlays on second molar teeth, and I really like gold inlays if it's a DO or an MO. I've got patients that have had gold restorations in their mouth for over 50 years. You can't break them. Any tooth-colored restoration can break if somebody bites down on something hard. I'm using this football diamond, coarse football diamond, for facial and palatal reduction. It cuts a lot faster than a barrel diamond. Then I'm going to come back with a barrel diamond and finish the preparation, and the final finish will be with a flame-shaped fine diamond or a fine chamfer diamond. Be sure everything draws and all the line angles are rounded. So this preparation is going to be just slightly subgingival, about 1/2 millimeter. So this is my occlusal reduction. I want about 2 millimeters, rounding those line angles. All right, now I'm removing the old veneers from the maxillary anterior teeth, and this is a coarse football diamond. I want something that will cut pretty aggressively because it's harder to cut old restorations off of teeth, especially if they're lithium disilicate, and if there's zirconium, that's really difficult to remove from teeth. The only thing I use zirconium for is if somebody wants a tooth-colored restoration crown on a second molar tooth or as a substrate for a bridge. I'll put lithium disilicate over the zirconium substrate. I believe these were lithium disilicate veneers. We had lectures at my teaching center in Dallas when that center was ongoing for 20 years, and they said Several of them said you can't break a lithium disilicate Emax crown. Well, that's just not true. We've all had those break. I've had zirconium crowns break. So anything tooth colored can break, and make that clear to the patient. They can help themselves by chewing softly the first few chews of any bite, but the only thing that won't break is a gold crown or a gold onlay or inlay. I want to reduce the incisal with retractors in place, lip retractors, and I want the patient sitting up in the chair looking at me so I can be sure to prep the incisal plane parallel to the pupillary line, the floor, and the lower lip. This is a great burr to cut interproximally. You always want to include the interproximal with a veneer. So with a veneer, you want to include the interproximal, the facial, and the incisal. It's called wrapping. You can watch my video on the importance of wrapping. Dr. Pascal Monnier and Douglas, when Pascal was at the University of Minnesota, developed this technique, and there are many advantages of wrapping the veneer around the interproximal, the incisal, and the facial. You don't ever want to put them only on the facial. There's many reasons for that I'm not going to go into in this video, but you can watch my video on wrapping. And there's also the article that Dr. Monnier and Douglas wrote on wrapping in the library of dentistrymasterclasses.com. You want to be sure the interproximal draw. Just want a steady hand and just go straight through, overdrawing just a little bit. If you underdraw or overdraw, you'd rather overdraw just a little bit, because the retention is going to be dependent on bonding, not mechanical retention. Following the preparation with the coarse football diamond with preparation with a coarse barrel diamond, just to even everything up, be sure everything draws. And I'm going to prep down just about to the gingival line with this coarse barrel diamond. Then I'm going to come back with my fine chamfer diamond and my fine flame-shaped diamond for the margin, which is going to be about a 0.5 millimeter to 1 millimeter subgingival on the facial and about a 0.5 millimeter subgingival interproximally. I think it's hard to do these complex cases if you're seeing a high volume of patients. You've got to have a practice system that allows you to do a good job on these involved cases, and I don't think you can really do a good job with this if you're trying to see a high volume of patients. Like, I don't want to see anybody else that morning when I'm prepping or doing any of these long appointments. Be sure everything draws. The super bulges are what you're working with. You've got to eliminate those to get down to the margin, so you don't want a super bulge trying to seat a veneer. You've got to remove that so that you have a straight line from the incisal to the margin. So see, I'm about 1 millimeter to a 0.5 millimeter subgingival, but I'm in the sulcus. I'm not invading the biologic width. You do not want to prep into the junctional epithelium. If you do, you'll have irritated, inflamed, red gum tissue. Got to keep it in the sulcus. And you don't have to go to the bottom of the sulcus. Sometimes the sulcus is not very deep, so as long as you're in the sulcus, you're okay. But rarely do I go past 1 millimeter in the sulcus. The only reason I would go past 1 millimeter if I was removing old restorations and that person had gone deeper, but probably what I do is just adjust the margin in that sulcus and make it more coronal. You cannot invade the biologic width. You cannot prep into the junctional epithelium. Now I'm going to look at the patient from the front with her sitting up and adjust the preparations so that the incisal plane is parallel to the pupillary line, a line drawn between the pupils, which represents the horizon, the floor, the lab bench, and also ought to be parallel to the lower lip. So in a perfect world, your parallel lines are the pupillary line, the incisal plane, the lower lip, the horizon, the lab bench, the floor, and the gingival line. Now the gingival line doesn't have to be exactly parallel to the incisal plane, especially if the patient has a low lip line and they don't display the gingival line when they smile. If they have a high lip line and they display the gingival line when they smile, you may want to do a crown lengthening or a gingival grafting prior to veneer placement, depending on how much of a discrepancy there is between the gingival line and the incisal plane. I've got a number of cases in the library of dentistrymasterclasses.com on creating an ideal gingival line and an ideal incisal plane when they weren't ideal preoperatively. See, this gingival line is fine, but you can see how things are shaping up. And when I get through prepping the teeth, I'd like the incisal plane to be parallel to the patient's lower lip, and I'd like the incisal plane of the centrals to be parallel to the pupillary line. Now, what if this tooth was broken? Would you prep this tooth to that level? No, you would not. But if they're virgin teeth or there's nothing, no broken part of the tooth, then you want this incisal plane, especially the incisal plane of the centrals, to be parallel to the pupillary line. That's the Dental Minute. These techniques work, and they work every time.
It's time. It is time to take your dentistry practice to the next level, and you know it. You just haven't known how to do it until right now. That's where dentistrymasterclasses.com steps in. At dentistrymasterclasses.com, Dr. Cutbirth is offering you his greatest work and his best cases. Here's everything that you're going to get when you subscribe to dentistrymasterclasses.com. Incredible comprehensive cases not seen in Dental Minute videos, an organized library of all the Dental Minute videos, and Dentistry Masterclasses comprehensive cases for study and reference. And you're going to get before and after photos of Dr. Cutbirth's fantastic restored work. So, great deal. $40, that is it. For $40, you're going to get all of this. So go right now to dentistrymasterclasses.com and subscribe today and change your life, change your practice.